Hey all, we are going to begin in just a second. We're waiting on just a couple more people to arrive, and then we'll be getting started. Thank you. It's a really this setup is very professional.
Hey, make it work.
It's funny, whenever you try and zoom, it's never the right angle, it's never the right. Yeah. Oh no. Okay. Not gonna use that.
I can just project.
Yeah. And then this will be for questions in the audience. This one we don't have issues with. Testing.
Oh, I hear it.
Okay. That's what I'm gonna do.
Like this, and everybody said they couldn't hear anything else.
I know, same.
Okay.
Hello.
Thank you, Nathan.
You guys have not met, right?
No, we haven't.
This
I'm
is
Caroline.
This is Caroline Soper.
Nice to meet
Okay.
you.
She's
Yeah.
here to Abbott, talk about DDS, and this is
Okay.
one of our favorite patients, Cedric Spain.
Dr. Carrick's already reached out.
Yeah.
Some
Some of her favorite people.
We're in for a treat.
Okay.
Yeah, and then
I was at the
Kelly.
wrong place. I had to run all the way up here.
Sorry about that. We,
Okay.
we have one new person.
You physically came up here? You physically
Yeah.
did it?
That's not a testament to what CBS can
Oh, will you call Dana and let her know that will you call Dana and let her know that Cedric is here? Thank you. Did you hear me or no?
We'll let you catch your
I
breath.
said, will you call?
So let me go ahead and plug this in.
Okay.
Cedric, you're actually gonna be right here.
Okay.
If you wanna come over here.
Just say Mark anytime.
Okay, I will.
And where are we talking? Are we sitting right here?
We're kind of gonna just stand it here. We'll probably be off screen, to be honest. I just want to make sure that they can see the presentation and hear them.
Okay, so we're telling them.
Yeah.
Okay, that's perfect.
Well, they're getting. Hello. There we go. Well, they're getting set up. I will introduce myself. For those on Zoom, I apologize, I'm off screen, but I'm right here. So I just wanted to take a second to introduce myself. My name is Logan Banks. I am president of the board of the Parkinson Support Group, CSRA. I'm going to take off my mask while I am speaking. So I just wanted to thank you all for coming. I know we're kind of, as always, it seems, in a little bit of tumultuous times right now. So I appreciate everyone that came out here physically. I still appreciate all of you that are joining us via Zoom as well. If you have any questions about anything that is spoken about here, please feel free to reach out to Martha Ann. I always do a shameless Martha Ann plug for questions, because she can connect you to pretty much anyone in the world. And then I also wanted to share with you that you can reach out to both of our panelists, because we're doing kind of a new age support group meeting today at however they would like to be reached. So I'll leave that up to them. Our speakers today, I have the bios here because I want to make sure I get it right. So we are pleased to welcome Cedric Spain, who will share his recent personal experience with DBS, and Caroline Sober, who represents Abbott, a DBS manufacturer. So we're going to start this off by Caroline sharing kind of what DBS is, to save Cedric some time from having to do that. And then Cedric can explain his personal experience. And then kind of if Caroline has anything to add on, best practices, we can go from there. So can everyone hear us on Zoom? Can I have a thumbs up? Okay. And then we'll also do a kind of a question portion as well, and I'll bring around the mic and we'll start a discussion. So we're trying to do more of a discussion formatted support group meeting every once in a while, so that everyone has the opportunity to ask the questions, the burning questions that you feel like maybe something that you don't want to ask your movement specialist or neurologist or whatever doctor you go to. So without further ado, I'm introducing Martha Ann.
Thank you, Logan. For those of you at home, sorry I can't see you, thank you for watching today. Dr. Julie Couric, who is our much beloved medical director of our Center of Excellence, is still in clinic downtown, so she's not able to be here in person. And I think I have met most everybody here several times, but if I haven't, I'm coordinator of our Center of Excellence for the Parkinson's Foundation at the Medical College of Georgia, one of 33 centers of excellence in the United States and one of 47 in the world. So I'm really proud to work directly with our providers and with you and help connect you with resources. And we also provide a lot of outreach. So a couple of things that we have coming up that we're excited about. This Thursday evening, you may have seen in our newsletter, in the support group newsletter, some information about a new interdisciplinary initiative that we'll be holding at the West Wheeler Rehab Facility. And this is open to anyone. We do ask that you call and register. It's from 4 to 5:30 p.m. at West Wheeler. And Dr. Couric is going to welcome everyone. One of our physician's assistants, Eli Coleman, will be presenting a sort of a mini PD 101 with questions and answers after. I'm going to talk about care partner strain and care partner burden, OT, speech, and physical therapy. We'll also talk a little bit about how they come into play to be part of a treatment team for someone living with Parkinson's. And then we're honored to have the director of spiritual services at the Medical College of Georgia about finding spiritual respite on the Parkinson's journey. So we're excited about that. If you want to know more, let me know. And then we are very honored and excited about an initiative that we're going to have in May. This is the first in nation, in person and streaming outreach addressing the unique issues and challenges of those living in the intersection of Parkinson's and LGBTQ. Cheryl Whalen, who's Director of Special Initiatives for SAGE, which is Services and Advocacy for GLBT Elders. Dr. Couric is going to talk about Parkinson's treatments and sort of their interplay and some other treatment. We have a neurosocial worker and LGBTQ activist from Jefferson Health in Philadelphia coming to talk about cultural competencies and how someone living in that intersection can find support. We have Dr. Matt Cradell, who is new to our psychiatry department in MCG, and he's a health psychologist and also an LGBTQ plus activist. And he is going to talk about cultural cultural humility, and increasing friendliness, LGBTQ plus friendliness in workplaces. I'm going to say a thing or two. We also have Annie Brooks Wallace, who's Director of Education for the Parkinson's Foundation, coming. So we're very excited about this, this national program. It's going to be May the 21st at the Kroc Center in Augusta, and also live streamed. There's information about all of these in the issues of the CSRA support group newsletter, and you can also contact me for information. And Dr. McLeod and Dr. Colin McLeod, one of our movement specialists, Dr. Joash Lazarus, a movement specialist in Atlanta, and I are going to present a program in June in Athens, Georgia. And so we're just excited to be here and work with you all. And if anybody who's here in person tonight would like a copy of this book, I have some that I can give you. And it's a phenomenal book written by a movement disorder specialist in Oklahoma who became a care partner when his mother was diagnosed with Parkinson's. And he's written this book called "You Are a Better Parkinson's Disease Caregiver Than You Think." I hear wonderful things about it. He took advantage of the shutdown during the pandemic to finish the book and get it published. And so we were able to purchase some of these with grant funds, and they're here for you tonight if you're interested in that. I also want to comment on our Care Partner Awards. You may have heard about these last year. They were new last year. And these, we recognize 3 outstanding Parkinson's care partners. This is going to be an annual award going forward. We award them in November at National Care Partner Month, but we will start taking nominations very soon. And this is to recognize someone who just is exemplary in their role of care partner. So I could name like hundreds of y'all that are like that. But any nominations can come from anyone. They can come from other care partners, providers, physical therapists, yourself, patients, anyone. The only requirement is that the person with the diagnosis be a patient in our program. And that gives me an opportunity. Oh, and the winner gets a $500 Amazon gift card and a beautiful crystal trophy. And that gives me the opportunity to say that Cedric Spain, tonight on our panel, his wife and care partner, Kelly, was one of our 3 winners for 2021-2022. So thank you. I'm here, ask the questions. I'll be hanging around a little bit afterward too. Thank you.
Thank you, Martha Ann. And thank you for allowing me to come and speak to you all. I'm Caroline Soper. I'm with Abbott Deep Brain Stimulation. And I had the fortunate opportunity to learn so much about Parkinson's and movement disorders with this position. I came from the spinal implant world, and it's an implanted device, but the patients were always unconscious, and then afterwards, you never really saw the patient. So I think this is such a unique panel discussion because Cedric can tell you, I'm sure he doesn't have an Abbott implanted device, but I'm sure you work with your rep a lot. Yeah. And that's been one of the gems of this position is I really get to understand the progressiveness of movement disorders, specifically Parkinson's and essential tremor, and what all is involved, and just kind of what Martha Ann was saying. I mean, there's a lot to it. I'm sure Cedric's gonna paint a much more visual picture, but it's just been such an incredible opportunity to work with the Parkinson's population. I just feel so lucky in that sense. But I don't want to steal Cedric's thunder by any means. So I just thought I would talk a little bit about DBS in general and how it affects with Parkinson's. I didn't want to do a really long, drawn out talk, because as Logan was saying, we're trying to make this a little bit more interactive as much as we can safely. But Parkinson's, as you all know, it's a progressive disease. We don't have a cure for it. You're not going to die from it if you get diagnosed with Parkinson's, but you will die with it. So it's this thing that needs to be treated. And unlike essential tremor, there are some additional side effects, and a lot of that comes with it. Where versus essential tremor, patients are more likely to live with it and they're less likely to seek out a movement disorder specialist. Logan and I were talking, you guys are so lucky to have a center of excellence at Augusta University. I cover the state of South Carolina and part of Georgia. And I mean, I work with a support group that they don't even have a movement disorder specialist within 100 miles. So they're constantly having to drive out of the area. So things like deep brain stimulation or new medications that have come on board in the last 2 years where they've been afraid to go to their doctors because of COVID, they don't know about. And so the biggest piece, and you guys are so lucky that you have close access to a center of excellence for Parkinson's and Augusta University and 2 wonderful movement disorder specialists. That's huge. That puts you guys so much more ahead of the game, because I find patients where, you know, they're being managed by a primary care physician a lot of times. And it's not the primary care physician's fault. They're trying to do the best they can, but there's just so much information.
I'm so sorry.
Oh, that's okay. I should know where it's coming from. There's so much information, and specifically, you know, I don't really talk a ton about medications. I'm not a physician by any means. I've never even sold pharma, so I really steer away from that. But with Parkinson's, your body is no longer making the dopamine that it used to. And because of that, that's where you're having all of these side effects like tremor, rigidity, slowness. And I'm not gonna, I kind of want to let Cedric tell his story and not, since we have an expert right here, but DBS is what we refer to it almost as electrical dopamine. So deep brain stimulation, it's a surgical implanted device. I have the battery actually up here that goes here, but then a functional neurosurgeon puts wires to specific targets for the brain, STN and GPI for Parkinson's. And depending on your specific diagnosis, you'll either get one side or 2 sides, what we call unilateral or bilateral. And there's stimulation, low pulse, sent via stimulation to those specific targets. And I have actually an on-off video because, Cedric, if you don't mind answering a question, now that you have deep brain stimulation, do you ever want to turn it off?
No.
Right. So we used to, prior to me being in this position, people like me would have a patient come and do these type of talks with them, and they would have the patient turn it off. But it's uncomfortable. And so I do have a little video that I wanted to share. But before I do that, does anybody have any questions specifically? Yes.
Once you have DBS, then you don't need to take the Cinemed anymore.
So that's a great question. Ideally,
Could you repeat the question just so we answer?
yes. She was asking for carbidopa-levodopa, and that's just the generic name. And that's kind of like when you want to consider a surgical option is when you are taking so much carbidopa-levodopa, which is a wonderful drug developed in the 60s, but it has a really short shelf life. So your body metabolizes it pretty quickly. And and it has some side effects. So once you're in this medication cycle where you're having to take so much, and then you're having side effects from the medication, that's typically a good time to start, you know, looking at other therapies like deep brain stimulation. There's some others out there as well. And so to answer your question, the goal is, you know, since deep brain stimulation is electrical dopamine and your carbidopa-levodopa is dopamine in a pill, the idea is you up the stimulation and lower the medication. So it's kind of like a scale like this. Most patients remain on a small dose of carbidopa-levodopa. Few patients go off medication completely. There have been some that do, but the biggest piece is that it dramatically goes down, which is the whole point of going through the surgeries, going through the imaging required to get the surgery. It's a huge decision. It's something you'll have implanted for the rest of your life. It's something that you shouldn't, take lightly. You should do a ton of research, talk to your doctors about it, talk to your family members. This is a huge, step. However, it's an amazing therapy that for Parkinson's is 95% plus efficacy. It's even higher for essential tremor. And, there are very few medications that I've ever taken in my life that have that 95% efficacy rate. So it is highly, it works. Yes.
About how many surgeries in a year, how many DBS surgeries would you say y'all want through your?
It's challenging. So she's asking how many surgeries annually. And it just depends. I've only known DBS during COVID because I started in January of 2021. And everything's been just crazy with OR time. And you do spend the night in an ICU after you get your leave-in placed. So with COVID, that's been a big deal because if you have COVID, you go to the ICU. So everything's kind of been weird. But when everything was pre-COVID, they were doing, 2 a week. So that's 8 a month. So over 100 a year. But just like anything, the Southeast, we don't tend to lead in technology and science. DBS is done a lot more frequently in the Northeast. Any other questions before we move on? So this is a gentleman. Turn it up. So this is an Abbott patient who was implanted. And this is the device, the controller.
When I press the button, it turns off and you will see that the tremor begins to return to my right side. It affects both my hand and my leg and is quite violent as a result of the DBS being turned off. When I try to do the testing that they always do, my left hand works fine, but my right hand is out of control. Same thing with my trying to touch my nose, or if I flip my hand back and forth, as I'm sure you've already tried yourself. The activation of the unit puts us back on, and you can see the cessation of the tremor and the calming effect it has on the rest of my body. Right away.
Okay, turn yourself back on.
He's a retired dentist, so he noticed the tremor initially because he works with his hands, and was diagnosed pretty quickly and really advocated for himself because he's a clinician.
I don't think my head.
Even though he's not practicing any longer, wasn't at the time, he still wanted to go on vacation. He actually went scuba diving on his last vacation and just, get back to living. So there's 3 different companies who do DBS device that work with Augusta University, and there's 3 companies in the country that do it all over. So I just really wanted to focus on Abbott and what makes us unique, and I just have a few slides to go through. And this was kind of pre-pandemic, but telehealth preference is obviously the way everybody wants to go now. Even if you live, like you guys, close to an academic center of excellence for Parkinson's, if you don't always have to go in, if you can be seen virtually or do a doxy visit, then most patients are appreciating that. And then you have patients that travel hours sometimes just to get to a medical center to see a movement disorder specialist. So those people specifically are really happy about virtual clinic because sometimes they don't have a caregiver. Not everybody has someone who can drive them to these appointments, or sometimes they can't take off work, or, there's just some other social issues too that prevent people from getting to their doctors. So knowing that, Abbott launched what we call virtual clinic, Neurosphere. And Neurosphere, it's award-winning. It's at one time one of the best inventions of 2021. It's an Edison finalist award. This technology is allowing patients not only get see their provider, their movement disorder specialist remotely, but also have programming changes. So the question that you had about going lower on the medication, so that's the whole idea. But then there's a balance because you want to up the stimulation and lower the medication, but sometimes there's an overlap. So you might be having some what we call dyskinesia, which is too much dopamine in the system because you've got it from a pill form and then you've also got the stimulation. So you could see your movement disorder specialist and say, I took what we talked about in the clinic, but it's way too much. I think I need to slow down. I want to show you my dyskinesias. Then you could get on, we have a relationship with Abbott. So each patient gets an iPod, or we can put it in an app on their phone. And then the clinician could see the patient and they could actually see the dyskinesias and say, oh, I see what you're saying. Yes. So maybe let's try lowering your morning dose. And maybe we take like a half a pill at night. So there's this titration that's involved with DBS, trying to get them to a good setting. And all of that is able to be done remotely. And 84% of patients surveyed would prefer to see their DBS doctor for device adjustments without actually having to visit the clinic. So you just need to have Wi-Fi and you need to have your device, either the iPod that comes with the implant, or we can put it on your phone. This is the iPod I was talking about. It uses Bluetooth technology. The whole point is we say we're app-based, we're upgradable, and we're wireless. And this is why. You don't charge anything unless it's your phone. And the reason why we're app-based is you could literally be sitting here and you could be, it looks like you're checking a text message, and you could literally be upping the stimulation on your device or lowering it, depending on what activity you're doing. So that's what that looks like. And our Bluetooth, you don't have to carry cords, you don't have to charge anything, it's wireless. And this is here's an image of the clinician, and Dr. Julie Couric has done a few of these. And that's the patient. This is what the clinician would see. And then you're seeing your clinician. But if you look right here, this shows the lead in the lower left-hand corner. And that's showing what program your specific anatomy is on. And you can make changes. You could change, the frequency, or change the stimulation amplitude. And this could be all, if she's at home, she's here, she lives here, or she lives, 4 hours away. The physician experience, there are a few steps. So that's where my role, I kind of come in and help the physicians get onboarded, show them how to use it. It is, some buttonology of what to do, where to go, but it's pretty intuitive. If you have an iPhone or an iPad, you'll know what I'm saying. It kind of walks you through the steps. And then that's what you would see as the patient on your device, your phone or your iPod. And then this is FDA approved technology. It's the same for DoD, crypto all of that stuff. So it took a while to get approved, but here's the way we've gotten around it. Because the total fear would be, what if somebody could hijack your Wi-Fi and have start messing around with program settings. So the way they've designed it, the patient has to initiate a remote session, and then the clinician has already been pre-mapped to the patient. So nobody else can make programming changes except for a clinician who's already pre-mapped to that patient. So even if you're a movement disorder specialist in the same clinic, if you're a Dr. McLeod patient, you can't get programmed by Dr. Kura. It's very specific, and it's specific to the serial number of your implanted IPG. So once the patient initiates it and the clinician clicks on that specific generator, then it'll say, Dr. Kura, Dr. McLeod would like to start a session. The patient has to click yes. So you're always involved in initiating it. And that's just a little bit more of what it looks like, the technology. And there are certain things. We have surgery mode. So a patient does have an implanted DBS device, they can get a surgery. I can show patients how to put themselves in surgery mode or MRI mode. However, you cannot do that virtually. You would have to do that in person. So I need patients to do that, or I can tell them how to do it over the phone. And what it does is essentially stop stimulation and protects your battery so you can get the MRI that you need or the surgery that you need, and then we just turn you back on. But all of those can't be done virtually. And these are the references used. And this is Abbott. And that's it. Yes.
Is this stimulation constant?
Yes.
It never ends.
Right. And
What's the intensity?
yes, so we are what we call constant current. There is another manufacturer that has voltage, and so it's not, but it's a little different. I don't know as much about voltage, but I do know constant current. So we don't have a rechargeable battery. Ours is a primary cell. And so what that means is you never turn it off, you never turn it on. We kind of say it's set it and forget it. You never, because the whole idea is you want to stop worrying about Parkinson's and start focusing on everything else. Yes. So we have clinical data that I think I turned it off. We have clinical data that looked over 202 IPGs, batteries, and for bilateral, so 2 leads into 1 battery, with average settings. And what I mean by that is you'll have some people who have a really strong tremor, or they have some other side effects that they need to have the amplitude a lot higher than others. That requires an energy source. But if you're on average settings, 2 leads, we have 5-year data saying 5.6 years is the average.
And then you get a new system, or you get a new?
No, these are all great questions. So the lead system is the most important surgery, and you do that once, and that stays permanently. But we do say, that's why that surgery is a lot longer. And so one thing people always ask me about when I first meet them, and I'm sure you had a question about this too, is you are awake. You are asleep for when they make the opening to put the lead or the wire to the brain, but then they kind of back off the anesthesia in the OR, and they're monitoring everything. They monitor your blood pressure and all that, and they lower it. And then they say, all right, Cedric, we're going to talk to you a little bit. We think we've got the lead in the right place. And then the rep is in the room. And the reason why we do all this, and the functional neurosurgeon's there, the movement disorder neurologist is there. It's a lot. But the reason why is because once you place the lead, it never moves. So we actually run a low level of stimulation in the OR to make sure. Do you remember any of this?
Oh, yeah.
You do? Okay, because you're still on anesthesia. I mean, you're not, you wouldn't want to like drive a car or anything. But, you know, they'll have patients, do you remember doing this and touching your nose, all that stuff? So the reason why we do that is because everybody in the room wants to ensure, and then I'm the device rep, if it's my product, and then I'm running stimulation to make sure they're getting that side effect and that benefit that they're looking for. So it's a really tertiary process because they want to make sure once they're done with that, they never have to interrogate the brain again, unless they do the other side. Then they get their battery. The battery's done 10 days later, and it's an outpatient procedure. They create a pocket, the battery slips in, they connect to the lead that goes behind the ear, and it's all under the skin. And so when you get a battery replacement, say it's, you know, 4.5 years later, your battery's dying. All they do is open that pocket back up, pop it out, put a new one. Patient goes home same day. It's a 45-minute procedure. So the big one that you stay overnight in the ICU for one night, that's for the lead placement. Great question. Yes.
Did you say the lead hides underneath the skin? Did you say the lead comes underneath the skin?
The lead goes in the brain, but then it comes up and we have like a cap system that locks the lead. And then that's all under the skin. You know, the skin on your head grows over it. But then the lead is tunneled under the skin behind the ear. And then you have an extension that connects up here behind your ear. And then it goes under your skin. And I actually have it, I can show you. And then that goes, you know, over your clavicle bone. You can go under the pectoral muscle. Most people don't, but you can. And then the pocket for the battery.
Do you have more early onset or advanced Parkinson's patients for this procedure?
Both.
Could you repeat that question?
Yeah, she just asked, is DBS an option for early onset Parkinson's or advanced? And, you know, I was actually at a talk, Dr. McLeod was doing a talk with the residents, and he was saying, you know, it used to be 3.5, 4 years after diagnosis, they would talk about DBS. But now, you know, they're trying to plant that seed a lot sooner because, you know, if you have a heart attack or develop AFib, a once surgical candidate is no longer a surgical candidate. So there are, you know, that's why you have to like first things first, always make sure you're conversing with a movement disorder specialist and talking with them. They're, especially with Augusta, you know, they're very well versed on all the 3 different companies, all the different guidelines, all the different medications, and they're going to tell you this is something we should consider. And then, you know, it's up to you though. I mean, if you're not ready for it or don't want it, then absolutely that's your choice. But I think a long time ago, people saw it as brain surgery that you didn't necessarily have to have because you weren't going to die from Parkinson's. So I think old school neurologists didn't really talk about it as much to patients, and people just didn't have the option. And by the time they kind of looked at deep brain stimulation as last resort, and at that point, sometimes it's not, you know, it's not a good option. I mean, let's ask Cedric. I mean, how old were you when you?
It was 2015, so I was 35, I believe.
39 when I was diagnosed with early onset, and that's when I had my surgery.
So how long had you had Parkinson's before?
I was diagnosed July 1st, 2015.
How old were you?
So I was 39.
Okay. And then how old were you when you got implanted?
That took place in last year, so 2021.
Right. So 2 years. And just, it used to be, you know, 4 years post-diagnosis, they wanted, you know, they would start talking about it. So there's just a lot more information out there now and a lot more studies are being done. And are you glad you've had it?
Yes. I do it all over again a million times.
Yeah. Even though I'm sure it was scary
Yeah,
to hear a brain surgery procedure.
yes, yes.
So what made you decide to do it?
Well, for me, what happened is when I was diagnosed in 2015, being 39 years old and being a father of 3 kids, I wanted to have as much time with them as possible as a dad, as they know dad. We have 2 sons who are older and a younger daughter. And we always say that my 2 older sons know who Cedric was pre-Parkinson's. And my daughter basically knows me having the Parkinson's. What the DBS has allowed me to do was to regain control of my life, basically. First off, I know Parkinson's affects everyone different. For me, it was the rigidity, stiffness. I would freeze a lot. My balance was off. But after having the DBS surgery, all of that pretty much went away. The other thing it helps with is when you're taking 40 pills a day, I'm down to 15. It changes your life. It really does. It gives you control back over your body. You take for granted reaching down and tying your own shoe. And it's allowed me to do that again.
Yeah.
Yes.
You said you were freezing a lot, and did this make a difference on that?
Yes. Yes.
Could you restate his question? Sorry, I just want to make sure.
He asked, was I freezing a lot before the surgery? Yes, I was. Even on the medication I was still freeze sometimes.
And that's a really good question because typically DBS doesn't address certain side effects like freezing, gait, sometimes swallowing. But then like Cedric pointed out, everybody's different. Their anatomy is different. So sometimes you'll have a patient that shows tremors just on one side, but then they do the one side and they're like, wow, this side's so much better. You know, and if they do the lead on this side, this is kind of funny. I'm sure this kind of threw you at first. You know, right brain controls left body.
Yeah.
So if they do the right lead and you're left, you know, sometimes a patient will be like, this is so much better. I never noticed I have a tremor on this side. But then you'll have patients that present tremors on both sides and they do one and they're like, you know, I'm pretty happy with this just one. It's, you know, I feel like I've gotten some stability and this one doesn't bother me. So it just, each patient presents differently.
I had both sides done because when I was diagnosed, my left side was my weak side. I'm right-handed, but my left side got really weak. I couldn't move it, couldn't write, couldn't function. And after DBS, like you said, it does throw you because they tell you that to get to your left side of your body, they have to move the lead to the right side of your brain. So,
Right. But you get used to it.
yeah, you do. You do. When you're considering this surgery, this is the only advice I could give you. Just think about the quality of life that you want to have, and it is brain surgery, which is scary. But I mean, my doctor, Dr. Keurig, was there in the operating room. She walked me through it. It is kind of unusual when they wake you up and you're on the table. They're asking you questions, ask you to tap your fingers and touch your nose and what day is it, things like that. But after going through it, it took me basically, my first procedure was on March 17th, then March 24th, then March 30th. So it's kind of back to back to back. And then after that, you wait a month or so and come back in and they set your settings, your voltage settings.
Yeah.
Are you always aware of it? Are you afraid you're gonna hit your head or your chest or something?
I am always aware of it, and I am aware that I could potentially hit my head the wrong way, but, it's buried under your skin pretty nicely, so it's not going nowhere. It'll take a really hard hit. Yes.
Assuming that the surgery is successful, what are the potential downsides? Yeah, you've covered some of that, and it will affect some of the symptoms. But are there any others that we should be aware of?
I can tell you like indication wise, and then we'll let Cedric tell you in real world
Could you
evidence.
restate that question? I'm sorry.
Sure, no. The downsides of DBS. Well, one thing I will say is it is reversible in that say you get it implanted and they turn you on and for whatever reason you hate it, you can turn it off and it's like it never existed. I mean, it's a lot to go through just to never use it. But I mean, we always say it's reversible, where there's some other things that you can do to treat Parkinson's that are not reversible, like the high frequency ultrasound, things like that. So that's one good thing. Any surgical procedure, there's always a risk of infection, you know, just because you have an opening in an OR environment. So there is that. But I mean, I always, like my mom recently got a hip replacement and I just couldn't believe how invasive it was. And she didn't think twice about it, didn't think twice because it's just the way we look at it. And they sliced half her body open and she had to do a ton of physical therapy and she's good, but it was not like, I couldn't believe she didn't really think it through further and maybe like pick a good time to do it because it really did take a long time to heal. Where DBS, I feel like it's the opposite. People are, it's like, oh, I'll only do that if I absolutely have to. And there's the same surgical risk, just like if you know, got any kind of operation.
That was my big thing, worried about somebody cutting up in my brain. And it could be scary for some, but if you do the research, the benefits outweigh the risk.
But you could have, you know, a brain bleed. You could.
That aside, I was just worried about the possible downsides of a successful implant.
Yeah, oh,
Things could go wrong, I guess. Is right.
yeah, I mean, the biggest thing that I see of successful surgeries of a well-placed lead are just patients that don't go and get programmed. You know, it's either too far to go or they just don't make time for it. And that's not really what it's designed to do. It's designed to address all of your symptoms, you know, from a tremor standpoint, rigidity, not necessarily the freezing and gait, but he saw a benefit from. But you want to go and get titrated so that you're always kind of addressing as your disease progresses, you can address it by upping the stimulation. You had a question?
Yeah, I was just gonna comment. So, you know, I'm also like a coordinator, but I'm also a licensed mental health counselor, so I deal with a lot of the psychosocial aspects, you know, Parkinson's, and I teach a couple courses on that. And so we also know one of the negative things that can happen in some cases with DBS is it's important to have a thorough psychosocial eval before you have the surgery. Because you just think about, you know, issues that may happen, somebody is physically better, but you know, if they're having some psychoses or things like this that aren't being treated, and that can be causing problems. So that's just part of that being vetted and you know, being an ideal candidate is that's just part of that, is getting that thorough psychosocial assessment and maybe kind of the issues that are going on over there, assessed, evaluated, and treated.
And I did have to have a psych evaluation done.
Every center I work with, you have to have an analysis done for your cognitive ability. So Augusta University, they do it, you'll be fine. But yes, she's exactly right, because you can have, I mean, you're interrogating the brain. So you want to make sure that there aren't any things that could go wrong.
I do want to say, as a Parkinson's patient, that's something that you should already be continuously doing Because you never know, I mean, that's the biggest thing with Parkinson's, is you never know how it's going to present. So those psychosocial situations, you want to catch them earlier rather than later, because they can, I mean, Mark Ann, I'm sure, has horror stories of people that have put themselves without realizing it in a dangerous spot from a psychosocial standpoint.
Yeah, you're talking about the Parker DBS.
Yes,
Yeah,
yeah, I'm just saying as a disclaimer, like, you should be having those conversations.
Right.
With someone like Martha Ann, that's why we're so
Yeah.
thankful to have her.
Totally, yes.
So, I'm hearing that it treats some of the motor symptoms. Does it also treat non-motor symptoms that are brought on by Parkinson's?
For me, it has,
It has.
yes.
What specifically are you asking about?
Could we restate that question too, because that's more important.
What specific non-motor symptoms are you?
I'm just talking in general.
Yeah.
I mean, there's a trove of non-motor symptoms that go along with Parkinson's. Constipation, hallucinations occasionally.
What?
I haven't experienced any of that.
Anxiety, depression, sometimes is part of, I just know that there's a trove of, and I was just curious.
Absolutely.
The only thing I experienced is having vivid dreams.
Oh, vivid dreams,
Does
yeah.
it change the drains problem?
No,
I mean, that's essentially, you still have the drainage.
yes.
Yeah, 'cause that's a side effect.
Anything that it's helped you with tremor, what would you say?
Say it again?
I said, was the main symptom that it, helped immediately was your tremor symptom?
And the rigidity and the
Right,
stiffness,
tremor.
yes, yes.
To answer your question, I will say most of the patients that I see in clinic, there is some level of anxiety or depression, just because dopamine, serotonin, and oxytocin, I mean, they all affect mood. So, that's always kind of a piece of it. But then, there's trying to get out and be more social. And especially if you're not so concerned about your motor symptoms, then you'll be more willing to go out. Physical therapy is also a huge piece of it. Movement is huge. I know everybody's heard, if you don't use it, you'll lose it. But that's been the biggest thing too in helping movement disorder patients too. And I think that kind of helps with mood.
And exercise and staying active and moving as much as possible, even
Yeah.
though it's difficult.
Did you get therapy after your surgery?
Yes.
So did you ever feel like, once you were in the process, that they were pressuring you to go forward with it? Or did you feel like at any time you could back out?
Not at all, not with my team. Dr. Kier she was there the whole time, walking me through everything, and it's just, you really want to make sure you have a good open, honest relationship with your neurologist. Tell them what you're feeling, tell them what you're not feeling. Any little thing that you think that they need to know, please tell them, because it could affect the surgery.
How soon after the surgery, did you see the change, the results?
The first night was crazy, but after the first night, within 2 to 3 weeks.
Yeah.
She's back here, everyone,
I got
she's nodding.
I almost asked you a question earlier, but I was like, oh my God.
You can, I'm here, but I think I'm the other expert, I believe. But just to, repeat your question, Sonny.
Well, how soon after the surgery,
Okay.
did you feel like it was actually, improvements in the physical?
So there was, some immediate, success.
Hmm.
So, no tremors, it wasn't there. The process that, I guess was frustrating for us was during the titration process, because Dr. Kier wanted to literally start him slow and then work his way up. Next month will be a year with the DBS, but it literally took 10, 11 months just to get him where he is now. So maybe even a month after, there was still some rigidness, but it was just getting to the point, at her favorite word is getting to the sweet spot. Yes, yes. And so Cedric met with Dr. Curie. We were going there every month just to make sure. There was sometimes there was some setbacks as far as it was too low. And so he was constantly slow, he was constantly rigid, he was constantly not able to move at all as if it was pre-surgery. And so I would call, over weekends, hey, okay, what's going on? There were other times where it was too high, because we have the remote control, and he's able to kind of, like she was mentioning, either put it up or take it down. It was too high. And that point was, he was trimming all over the place, nonstop. So literally it took us 10 to 11 months to get him to where it is. And right now it's as if, he doesn't even have Parkinson's at this point. But again, it is a slow process, which is the frustrating part. Because I'm thinking, okay, well, he had the surgery, we should see some immediate, no. You have to get to that point, but it is well worth it. He's now driving. He hasn't driven in 4 or 5 years since his diagnosis. He's now driving. He's even putting in an application for a part-time job, and he hasn't worked since, 20 when he was diagnosed. And so there are rewards. It has been the best decision that he has made, that we have made. So yes, it is scary in the beginning. Do your research, get your support system that's around you, talk about it, pray about it, however it is, but it is the best decision that we could have made, just to get to that point.
And your support system is big. You have to have support. You gotta understand, when you were diagnosed with Parkinson's, your family around you had it too. Whether they really do or not, because they're gonna be there for you when you're sick, when you're high, when you're low. My wife, she is amazing. She helps me remember my medicine and keeps me on track with that. So your support system is huge.
And you're so lucky. I mean, I see patients who don't have that. And that's where things like remote care is huge, because they don't have like, if you can't drive and you can't physically get to an appointment, you can't get programmed. One thing I wanted to ask you, when your amplitude was too high, did it feel similarly to being on too much medicine?
Yes.
So
Yes.
you all, I would imagine if you have Parkinson's, take Harvard or believe it, but imagine if you had too much, your dose was off, and you had all the dyskinesias, that's what it would feel like.
What's the age range that they have been, using BBS in people?
I mean, at MUSC, they implanted a 91-year-old, but it was a really young 91-year-old who was healthy and exercised. And then, you can be a really old 60-year-old, where if you're, extremely overweight, that's going to be hard to get approved for surgery, or, if you're a smoker, just things like that, that'll take you out of the option of getting surgery.
I have a question right here. She's raised her hand like 5 times.
Thank you. I have 2 questions. One is, do you feel any of the electrical energy or impulses?
At times you do. The reason I say that is because like when you wake up in the morning, you feel a tingle and you know it's there.
Is it uncomfortable, painful?
No.
What does
No.
it feel like? Like
Like someone trying to tickle you, but in the brain.
Could you repeat what she asked to? Because I just want to.
Yeah, she asked about, do I feel the pulses when it happens? No, I mean, once the day gets going, you're good. But yeah, you feel it a little bit, and especially if it has to be adjusted, then you really feel it.
Thank you. The other question I had is about the adjustments. If you're seeing somebody roughly once a month, but you feel you need adjustments, in between, how easy is it to get in to see it?
In my situation, it's fairly easy. Dr. Keurig does a great job with her patients. She sees them when she can, she work you in. But again, having an open line of communication is key.
And most places try to get you in. I mean, they're there for you. It's just sometimes there's too many patients. We had a patient in Charleston who was implanted in Charleston but lived in Greenville, South Carolina. So it's 4 hours away. And she had a car wreck and she was fine, but she just wanted to do like what we call a system impedance, just to make sure everything was still intact and nothing came disconnected. And she couldn't come that day. So they did a virtual like system impedance, but then they got her in the next week, to see her in person, just to make sure, everything was A-okay.
I would imagine that it's even easier with like a remote system where someone can come in
Yeah.
via iPad
Yeah.
as well.
So, well, this is gonna seem paranoid. And maybe it is, but the wireless aspect is always subject to interference and hacking and that kind of thing. Is it always, is that the only option, wireless, or can you do it non-wireless?
No, in-person care is always superior to virtual.
No, I mean the programming, the controlling.
On my remote control is wireless and it's Bluetooth.
Yeah, so I mean, with that Bluetooth technology, you just need to be within 6 feet.
Right, I understand that. Maybe, like I say, this could be perceived as paranoid. He's concerned that somebody being able to recover on that.
Yeah.
Unwanted,
So all 3 companies have
malicious.
FDA approval. So what that means is there's a certain level of, I mean, I can only speak with Abbott, but there's a certain level of crypto security to avoid that. Otherwise it wouldn't have gotten approval, because for that exact same reason. Just the virtual clinic had to get an additional FDA approval, because you could be sitting at home and what if somebody could hack your serial IPG and make program changes?
Right.
So that one is the same crypto technology that the DoD uses. That's why it took so long to get approved.
Same one with banks use.
The example was DoD, maybe the banks, I don't know. Yeah, no, that's a good question.
So, so when you travel, does any of the devices have to be, you have to let the security check people know that you have this device? Or
Have you traveled?
I have not gone through an airport checkpoint yet, but
do you present that information, or do you need to?
I don't think you need to.
I mean, I would, just as you're going through, like, just so you know, I have it, DVS, you don't. I'm sure you got like a surgical card that you keep in your wallet.
Yeah.
So if anything should happen, they'll know he has DVS. It's more for surgery and like a really large, strong magnetic field like MRI. So the one that you're going through in the airport is really not, I'm just, I'm a mom, so I'm just like, just so you know, like this kid has this kid, like I would say it, but you don't need to. And I fly with batteries and I never have any trouble going through security.
What about the cost of it? You're too young for Medicare. But did you have a huge bill facing you, or
No.
who's covered?
Yeah, my insurance covered it.
Martha Ann, you might want to speak on that.
I mean, just my 2 cents thrown in, so Parkinson's is one of the diagnoses that allows you to be fast tracked for Medicare. So you can get Medicare at any age, if you have Parkinson's diagnosis.
And most commercial insurance covers it as well.
Right.
Ursula asked the question, and if you answered it, I apologize, I didn't get to catch it, but in Ursula's case, John is long-term Parkinson patient with a lot of symptoms that he has. You talked about the newly diagnosed. How do you determine based on the length of length and severity of the Parkinson's symptoms, whether you would be a candidate for that. What would preclude you from that, besides ill health otherwise?
I mean, again, I would just say get in to see Dr. McLeod or Dr. Kurek. Not all movement disorder specialists are pro DBS, and it might be they don't have as much experience with it, or they didn't train on it, you know, it wasn't big where they trained. At Augusta University, both of them are very well versed on DBS, and I just kind of steer patients towards them in terms of, you know, you can say, I heard about this, what are your thoughts? Do you think I would be a good candidate? Why or why not? And have that thoughtful discussion of, you know, well, I'm here, how much longer do you think I would have to make that decision realistically, you know, and what would prevent me? Because, you know, you can have a stroke and get DBS, but it depends on the severity of the stroke. If you have a heart attack, you're probably not going to feel comfortable moving forward with surgery. So there's just a lot to it that would be hard. I wouldn't feel comfortable answering it unless I was a movement disorder specialist.
And I will also say that at the beginning, when I was doing our outreach, the program that's happening June the 25th in Athens, Georgia, that's always, you can always watch virtually. It's the Parkinson's Foundation program. It's about surgical options. So we have Dr. McLeod and then Dr. Joash Lazarus. Joash is a movement disorder specialist in Atlanta. He has been at Emory and recently left to join another practice in Atlanta. But he is going to talk about what you're talking about. He's going to address sort of who's a candidate, what is this about, who's this work for, who's it not work for, why, who's it a good idea for, who's it not a good idea for, and then Dr. McLeod is going to talk about actual DBS. And then I'm going to talk about the mental health implications and care partner implications and things like that. So anyway, just that'll also, all this, I don't have that flyer out yet, but if you all get the CSRA Parkinson support group newsletter, which I suggest always everybody get that, and if you don't get it, the CSRA, because it does always tell you the programs that are coming out through our COE. And everything's always also virtual. It's always recorded to watch later if you want, and it's always free.
And it's same with these meetings, sorry, really quick, I wasn't expecting. These meetings as well, if you're joining us via Zoom or you're in person in the room, if there's things that were talked about and you want to go back to them, these are recorded and posted on our website and also to our YouTube channel. So you can access them both of those ways. If you're not on the newsletter, you're not receiving it, you can go on the website and sign up for a paper copy to be mailed to you, which is something that I don't think a lot of support groups do, but we do. Or you can get it via email, or you could do both. That's kind of up to you. So
the first thing I do after our introduction with new patients, I always have to go and sign them up for the newsletter, even if they're going back to their home in North Carolina or something, just because it's, you know, lets them know about clinical trials and outreach and things like that, that, you know, they may be interested in, they may see their doctor now want to speak at one of these that might be interest or something.
and like the rest of the world, we've now gone virtual. We're never not going to have a virtual component. So if you're in Canada or you have a friend in Canada with Parkinson's that wants to join the support group, we're only going to get more tech savvy. It's one of my personal missions as president is to keep us moving forward in that direction. So
this program's a Saturday, June the 25th. It's the Classic Center in Athens. If you know Athens, that's downtown. It's a really nice venue. But if you're in person or you watch virtually live, you have the option of asking a question, right? So you can type in that question if you're watching from your home or ask in person. That's the one advantage over watching it recorded later. But I would recommend that if anybody's got interest, if interested in that, after that information. Registration for that will open in the next month or so.
okay, now I'm gonna stop us.
Thank you so much.
You're welcome.
I have another question. I'm actually going through the evaluation process. I haven't heard anything in a couple of months. How long does the process take? Have an idea.
For me, it was,
Could you restate that question? I'm sorry.
How long does the evaluation process take?
how long does the evaluation process take? For me, we started, the day that they wanted to see me complete, there was a day I had to come in and I
had to be completely off my med for a certain amount of time so they can get a baseline of what they needed to do. That was,
It was a 3 to 4 process leading up, so the evaluation
Yeah.
included, the baseline, meeting with, the doctor, the psycho evaluation, a complete physical, and also the research. So it was really, 3 to 4 month period, but we were also in the pandemic, so a lot of things got pushed back as well. So it may or may not take that long.
And I know there's an MRI component.
Correct.
And I haven't heard anything. So I don't know.
The follow-up is always good. Follow-up is always good. So just call, because I know that, the MRI period that he had, he moved a lot. And so we had to actually go back because he had to be sedated. So then that result a little longer than usual. But follow-up is always key. Knowing that, the hospital, they're back up with a lot of things. So I know we had to stay in constant communication just to kind of follow up on certain results. But everything was always given to,
Question about the airport security. So that occurs watching, virtually, so she practices, so you say it can be detected by the police.
If we can touch with other DBS patients ahead of time, like a support network.
yes, Dr. Carrick actually had me call a young man about my age who had it, and I talked to him, and he started with the scary part, which is, thinking about somebody cutting into your brain and all that. But then he said, Cedric, I do it 100 million times over and over and over again because it gave him his life back. He was young. He had a couple of kids. He was a truck driver, and he had gotten laid off because it started affecting his job. And so, yeah, after he had the surgery, he was able to go back to work.
Have you had any falls or anything?
No,
No.
You participate in sports?
I stay active. Yeah, shoot basketball.
You just ran down here from the clubhouse.
Yeah.
When he came in, he said, "This is a testimony to what DBS can do for you."
Gonna make us all good runners.
I cannot guarantee that.
I'm so sorry, everyone. I know I gotta cut it short a little bit. We have to set up the room for tomorrow morning, and the staff is in peace with the patient waiting on us for 20 minutes. So, but I didn't want to interject. I want to thank everyone up here, these two, for coming and talking about their experiences and DBS in general. If you have any more questions for them, where can they find y'all, I guess?
I'm on Facebook at Cedric Spain, CEDRCSPAIN. I'm in a ton of support groups on Facebook, and I'm on Twitter at Cedric Spain too as well.
And I'm also, you can also, everybody's got my contact information. You can also email me questions or anything, and I will forward them to Cedric and to Kelly. If anybody knows interested.
Same for me, and
And
I
also Marlon McCarroll.
and I have cards too. If anybody wants, more detailed discussion or a phone conversation. And I just want to say, you're phenomenal for DBS to be able to talk about it and your journey and your process. I mean, this is what I want all patients to be able to have this dialogue with, because it humanizes the whole procedure, and you've been through it. And so I always recommend patients, potential DBS candidates talk with the patient. So this is what you guys are getting, such a gift. Thank you for coming.
Thank you both. I just want to encourage everybody to sign up for the newsletter if you haven't. Thank you all for joining us in person. Thank you everyone on Zoom, on Facebook Live for joining us. If you have any support group questions, I'm always available as well. My contact information is on the newsletter, on the website, it's everywhere. Same with Martha Ann's, so any way we can assist. Yes, Pam?
I just wanted to mention that there's a lot of free resource material back here on the left-hand side. On the right-hand side, there's calendars. Please feel free to take as many photos as you want. What we used to do with my mom is have a separate calendar related for her medical things. Symptoms that she might have and what day, so it's easier instead of trying to put it on a major calendar.